I am Lisa Blanchard. I'm the Chief Clinical Officer at Spectrum Health Systems based in Massachusetts. And I'm really here to share my perspective of the impact of parental substance use, really from the perspective of the parent or caregiver who may have experience with or is actively using substances. So you'll hear that throughout my portion of this training. I'm really representing the individuals, adults with substance use disorder, and recognizing that the children that you might be supporting with TFCBT, right? The parents that we're talking about now with impacts from substance use were very often those children at one point. And so I think that's a helpful perspective to think about. I'm going to just share some education on substance use, on medications for substance use disorder, and the rest of the training will be supporting how we support families and how we support children in this context. So as I mentioned, I'm going to share a little bit about the education of substance use disorder. And you'll see here that I have listed SAMHSA's working definition of recovery. And it really includes all of these things, right? Not just what substances are being used, how often, that what those substances are, but really that individual person in all of the parts of that person, right? So somebody is not just their substance use. They're not just their addiction. They include all of these parts of them that are part of both substance use and recovery. And this is, of course, a snapshot in time. But, I do want to share some statistics. And of course, these change consistently year to year over time. And hopefully they continue to trend in ways that support those that we are caring for in addiction treatment programs. And we've seen some drops, right, over time in overdose rates, which is really promising because that has not been happening consistently. But I do want to highlight that where we're seeing overall overdose rates drop, we are seeing significant increases in some populations, right? So Black and Brown communities are significantly seeing increases in overdose rates. And so I think that's just helpful to recognize that this is still too many losses. This is still too many families and children impacted. And there are communities that are being impacted more than others. But we're going to start off with just talking a little bit about substance use disorders. And so we want to start with the kind of basic definition, right, from the DSM. Substance use is really that compulsive use of a substance accompanied by negative consequences. It's not just the use of substances that results in a substance use disorder. It's the significant negative consequences that continue. And we know that it can impact anyone. Of course, as you heard me share in those overdose rates, there might be more individuals in some communities who are more impacted or are receiving less treatment. But really, substance use can impact people across socioeconomic status, gender spectrums, ages. It really can impact all of us. And we don't know exactly what causes substance use disorder, right? There's no test you can take that's going to tell you whether I will or I will not develop a substance use disorder. But we know it's a combination of things, right? So it's a combination of your genetics. It's a combination of your psychological traits, right? Some inherent characteristics. But it's also a combination of your environment. Right? What have you been surrounded by? What have you been exposed to? And also what has happened to you, right? So trauma. Things that have happened to you. What is your stress level? What are the things that you have had to endure that combined with those genetics and environment and use patterns can result in a substance use disorder? But what we do know is that this has really long-lasting impacts on the brain. And I'm not going to share lots of details, but just to make sure that we're all speaking the same language, we're talking about lots of different classes of substances here. Of course, opioids tend to get a lot of the press. That's what often is creating this overdose crisis. And so we'll talk a little bit more about kind of what has shifted over time in the use of opioids, but it also could be stimulants. And we're seeing significant increases in stimulant use, things like cocaine or methamphetamine. And also cannabinoids, right? There's a lot of shift in perspective around that, but it really can complicate the picture of substance use. Depressants like benzodiazepines and alcohol, we are seeing significant increases in the use of alcohol across the country, and the admissions for alcohol withdrawal and alcohol detox. Dissociatives, hallucinogens, we're still seeing in our communities. And the reality of it is that it's not always just a drug of choice like we used to think, right? What is the thing that you consistently use? What's more the norm is that individuals who use substances are likely using several different substances. And that can really complicate the recovery process. There's lots of reasons for what we call polysubstance use, but it can increase higher risks for overdose. It might be to manage symptoms of withdrawal or intoxication and try to manage the ups and downs with other substances. It could be to manage mental health symptoms. So there could be lots of reasons why there'll be multiple substances that are used. And there's also just trends we're seeing in what's available in communities. And so things like co-dealing and having access to multiple substances with one dealer, right, one location can increase the risk of polysubstance use. And we hear an awful lot about overdose. And of course, that is what we're really trying to avoid because we cannot help somebody work towards long term recovery. We cannot heal families. We cannot support connection if we have losses. And so it's helpful for us to recognize who's at risk of overdose. And so, of course, the longer someone's using, right, the more experienced they are in use, the more likely they are to experience an overdose risk and overdose event. Individuals who've overdosed before, the more times you've overdosed, the more likely you are to overdose again, and the more likely you are to have a fatal overdose. And it's also anybody who has a reduced tolerance. And that could be for lots of reasons, right? That could be because somebody just left treatment, right? So maybe they went to a withdrawal management program or like what many people consider detox. And so they no longer have as many substances in their system. Or they even went on to longer term care, which can really support recovery, but can really reduce tolerance and increase risk for overdose if there is not medication treatment that helps support that. Could be anybody released from incarceration. We know that jails and prisons are a very big part of the picture of many of the families that are supported. And it also can be individuals who are just trying to reduce their use, right? Reducing how much, how often, what they're using, how they're using it in attempts to take care of themselves and have some harm reduction and work towards recovery. And that can also equal reduced tolerance and higher risk for overdose. And of course, if you're mixing multiple substances, as I've already described, that can increase your risk of overdose, particularly substances that have an impact on your central nervous system, right? So that will have a compounded impact, particularly with opioids and alcohol and benzodiazepines and other central nervous system depressants that can impact your breathing. And really, what we're seeing is a major change in what substances are available and therefore what substances are being used, right? So, synthetic drugs are what is happening now. They're widely available, inexpensive, and accessible, right? And so they're constantly changing, they're constantly being, available in different communities. And so that we're talking about is less of that opioid prescribed crisis, although still there's individuals who may have concerns about misusing prescription drugs. But really, what's available in communities now for opioids is fentanyl, and it is much stronger. Stimulants, a synthetic of that, it would be methamphetamine. And we do still see some synthetic hallucinogens like mephedrone or bath salts. In adolescent populations and in sometimes the incarcerated population, we do see some synthetic cannabinoids like K2 spice and things like CBD oil. But just to put a little bit of a picture to this, some of these are older graphics, but I still find them really useful because it's helpful to recognize that fentanyl is 50 to 100 times more potent than morphine. And so what we really are seeing is that the increase in overdoses is related to these synthetic substances because of how strong they are. They result in a higher risk of overdose. And this graphic on the right really does a good job of describing the difference between how much fentanyl equals how much fentanyl or carfentanil. You can really see, just how much more potent and powerful these substances and really poisonous these substances are in our drug supply. And we are nationally seeing increases in stimulants in general, including methamphetamine. And we're seeing more overdose deaths with stimulants, which we did not typically see before. Now, certainly there's lots of risk, risk of heart attack and death and risk of lots of negative consequences with stimulants, but they don't cause that central nervous system depression of stopping breathing. But because there's so much fentanyl in the drug supply, often there's fentanyl in substances that aren't even intended for opioids, right? Somebody could be looking for cocaine, trying purposefully to stay away from opioids and be exposed to fentanyl. And so that's why we're really seeing a lot of these overdose deaths with stimulants involved. And we're starting to see, stimulants and methamphetamines move to areas of the country that have not seen this before. In multiple factors, really that co-dealing I described before, in what's available in the drug supply is what is driving that. And this graph really just shows kind of over time what that looked like. And you can see, right, it's not methadone that's causing these overdoses, right? These synthetic opioids are opioids other than methadone. That green line there, you can see how low that was over so many years and then starting to climb in 2015 and exponentially climbing up until, the middle part of this decade. And that's what's really resulting in these overdose deaths. And you can actually see the decline in heroin over time. So that's all of the things that are happening, right? And why this is such an important topic and why we really need to focus on supporting families in recovery. But let's talk a little bit about what that is. Let's talk about recovery because recovery is absolutely possible. And there's varied definitions of recovery. People recover in lots of different ways. There's no one way in and there is no one way out of addiction. And so some people kind of have natural recovery, right? They just have a change in values, they have a change in their social structure, they just make some different choices, right? And decrease their risks and move towards recovery. I think a lot about college students who have really high risk substance use, get a job, and just decide that that's not fitting their lifestyle anymore, and they discontinue that behavior, right? But we also know some people just aren't able to do that even later in life, even when their environment and circumstances change. So natural recovery isn't always possible. A lot of times we need support, right? And so that's where supported recovery comes in. And that can be done in combination with formal treatment or on its own. At different times in the recovery process. So you could get family or spiritual support. There could sometimes legal or work sanctions can be a way to enter into a recovery process. But it also can be in a brief interventions, support groups, 12-step, other recovery support, all recovery meetings, lots of different ways that folks come together to support each other towards moving towards long-term recovery. And then there's, of course, formal substance use treatment. And that's really focused on that brain impact I mentioned earlier, right? So the formal treatment is going to support the need for that kind of long-term neurochemical changes. It's going to support that kind of up and down relapse remitting course that we see typically in substance use disorder, manage some of those significant health and social consequences. And really, those goals are individualized for that person, right? To reduce the impact of the substance use disorder on themselves, on their family, on those that they care for, and reduce harm, right? And hopefully shorten that course and work towards their own definition of recovery. And in treatment, there's lots of different components. So for clinicians who are listening, you're pretty familiar with the left side of the slide. So this is kind of the behavioral treatment, right? That's things that we're doing to enhance motivation for change. So building on motivational interviewing skills, finding someone's own internal motivational reasons why they would like to change versus why we would like them to change. And once somebody is in a more motivated space, we help them improve those skills for making those changes, right? We could do things like relapse prevention skills, and we'll add in things like cognitive behavioral therapy, helping folks kind of restructure their social environment, which likely needs to change significantly, change what they do all day. What are their activities? How do they spend their time? How do they structure their lives? And those are things we're used to doing in therapy and in counseling. And medication treatment really works well with that behavioral component. And it really supports stabilizing those neurochemical imbalances, relieving those symptoms of withdrawal, which really do drive use patterns, decreasing that craving for substances. If you've not heard anybody describe what withdrawal feels like, there's not much that you would do to discontinue those feelings, right? It's like I've heard it described as having the worst stomach flu and regular flu at the same time. It's really uncomfortable, and individuals know that using again is one of the ways in which you're just going to end that feeling. And so when we can decrease that withdrawal and relieve those symptoms and decrease that craving, we really can impact those use cycles. And it also can prevent that intoxication and overdose, that protective factor. And when you're stabilizing your body, it's allowing that brain repair, right? Allowing that time to support new brain pathways. And it really brings you back to a treatment team. You're connected to a treatment team when you're on medications. And so you have connection to the counselors and therapists that can work on the left side of the screen there. So it helps support that work as well. And I want to spend just a couple of minutes talking about medication treatment for opioid use disorder. There's a lot of stigma out there for using medication treatment in general, but particularly using opioids to treat opioid use disorder. And it's really due to a lack of understanding on how these medications work. And honestly, methadone is probably one of the most studied medications out there with so much evidence for effectiveness, but so much stigma for its use. So it's helpful to recognize what methadone does. It's a long-acting opioid, right? So instead of having to take it regularly at short-term intervals, like you would maybe when you've had a tooth pulled or had a surgery, right? It lasts longer throughout your day, which is why typically it's dosed once a day or sometimes split dose twice a day. And low doses start to relieve withdrawal. Moderate doses can support that craving. It's harder with fentanyl to get to a blocking dose, but it does support kind of that reduced overdose impact. And it's highly managed, right? So there's lots of changes happening in this portion of treatment, allowing more self-administered take-home medication and more flexibility, but it still needs to be administered through a licensed opioid treatment program that has all of those other psychosocial components associated. And then there's buprenorphine, which is a partial agonist, where methadone is a full agonist. And it can be prescribed in a flexible office-based way because it has a bit of a ceiling effect. You can't give more and more buprenorphine over time. It levels off. So where you can give more methadone to manage higher withdrawal symptoms, particularly in the context of fentanyl, and buprenorphine kind of does level off. And so it has a slightly different safety profile, so can be just prescribed, and there's less regulation associated with it. And patients control kind of those dosing times, which sometimes is helpful and flexible and supportive, and sometimes is not. And typically when you hear it prescribed, it's often prescribed with naloxone, which is Narcan. So what that does is it requires that if you were to take the medication in a different way, maybe intranasally or try IV use, then it's going to actually activate the Narcan. So nobody's going to choose to do that to themselves. And so have to take it in the way that it is prescribed. But it's available in several formulations now, so not just sublingual under the tongue, but injectable forms are available as well. And then there's naltrexone, and so many people think this is kind of the solution if you've got a stigma against using an opioid to treat an opioid use disorder. It's not an opioid; it's an opioid receptor blocker, and so it certainly does have its use case, and we need all of the tools in the toolbox, but it does not treat withdrawal. And so you've heard me describe pretty clearly that withdrawal really does drive use patterns, and so you have to have a significant period of time of no use, no medications for opioid use disorder, no opioids in your system in order to initiate naltrexone. And so that sometimes can be a barrier. It's available in oral and monthly injectable forms. It's also approved for alcohol and probably one of the most effective treatments for alcohol use disorder, but again, does not treat that withdrawal. So may have more use case for some of those step downs from a controlled environment of either incarceration or treatment. But now that there's agonist treatment available in a lot of those settings, you may not need to do that. And I just want to shift us to that impact of substance use in the parental context and in those that are caregivers. We know that some of the things that really contribute to use is not just that use and withdrawal cycle, right? But the stressful or unpleasant situations in our lives, the trauma, the things that happen to us, the negative events in our lives lead to negative feelings. And substance use is a really effective coping skill short term. And so those pathways are really deep. So often we use substances to combat those negative feelings related to the things that are happening in our lives. And that leads to shame and guilt, which is in itself another stressful or unpleasant situation with negative feelings. And the cycle continues on. And so, in order to really disrupt that cycle, we need to really take care of that whole person. We need to remove all barriers to treatment, open access wide, provide evidence-based treatment like medications, like wraparound support and peer support and clinical support. We need to treat the whole person in their mental health conditions and their trauma at the same time so that we really can disrupt this ongoing cycle. And lastly, I want to finish with the idea that the more we integrate care, the more we treat the whole family, the better off the family system is going to be, right? There's lots of knowledge gaps, even in the substance use treatment world, right? We're focused on the adults that I've been talking about this whole time. And we know that parenting is a source of shame and guilt, and it's hard to talk about. And so sometimes we avoid talking about it, right? Maybe we don't understand the child welfare system, or we don't want to ask questions we don't want to know the answer to, or we simply don't want to trigger our patient. We're trying to support them. And so we don't talk about parenting. And we really have opportunity to think about supporting that entire family system differently and integrating both the adult treatment system and the child welfare system and the family system and the child treaters together so we can all work together towards supporting long-term recovery, recovery-based supports, and connection for caregivers, parents, and their children.